A 38-year-old healthy female presented for a routine eye examination because she was running on contact lenses and that she had not seen in a year, and she needed new lenses. She had an ocular history of high myopia but was a successful user of daily wear disposable contact lenses. After change of the lens, she noted no any improvement in her left eye. Her left visual acuity was 3 over 60, while the right eye visual acuity was 6 over 9. She said that she began to notice vision loss inferiorly 1 week prior, which progressed to central vision loss 2 days prior to the exam. Upon a dilated fundus examination, there was a retinal lesion shown in the photo. Both clear corneas, clear lenses, as well as normal intraocular pressure and reactive pupils. Alright, so let's talk about retinal detachment, because that's the diagnosis for this case. This is a diagnosis of superior retinal detachment. And what is meant by detachment? It basically means that if we have the retina here, the retina consists of basically two things. The retinal pigment epithelium right here, and the neurosensory retina, basically the neural part of the retina. Alright? And basically what's happening in retinal detachment is there's a separation between the two. If there's a separation between the two, obviously, this will lead to disaster. This leads to affected vision, and you'll see on fundoscope examination a very obvious detached part of the retina. According, of course, not every case is detached. There might be a retinal tear that eventually leads to detachment, but overall, in fundoscope examination, you'll find basically part of the retina being detached as this grayish-white discoloration. Very obvious, and sometimes the detachment might come as a horseshoe-shaped tear. We'll come to that later on, okay? But the diagnosis here is superior retinal detachment. Patient had visual field being affected, especially in the lower part of the visual field, and then eventually progressed to the central region. So this lower part of the visual field gives you an idea that this is superior retinal detachment. It doesn't affect both eyes usually unilateral, and usually if you have the lower part of the vision being affected and you suspect retinal detachment, then it must be the superior part of the retina that's detached. If it's an inferior, vice versa, okay? Regardless, we should think of it as retinal detachment. And the thing that supports me is typically a patient who comes to me with retinal detachment, he'll come to me with sudden loss of vision. Affected vision immediately lost, and it's painless. And typically the patient will see flashes and floaters, abnormal lights known as flashes and floaters, abnormal dark spots in his vision. On top of that, the patient may or may not have infection in his pupil. In the case, I believe it's mentioned as normal, but in our case, typically it could be in severe case of retinal detachment. There's afferent pupillary defect. On top of that, the patient might describe that basically in the periphery of his vision, he might describe in the periphery of vision like there's a curtain. You know when you go to an opera or any opera, and they always have the curtain closed when a musician finishes his job or when an opera singer finishes her song? That's basically the same thing. The patient feels that there's a curtain closing in on him, and that's something that can be specific for retinal detachment. But the one thing to absolutely confirm this is retinal detachment, because there's a lot of differential diagnoses such as the retinal vascular diseases, the central retinal artery occlusion, the vein occlusion, as well as vitreous hemorrhage. The one to confirm it is through investigation. The investigation is, Saraha simply put, is fundus examination. That's enough. You can do visual acuity, visual field, a lot of other things, but the fundus examination is basically diagnostic for it. If you don't see it at all, or if you don't see the tear at all, you can basically maybe do ocular ultrasound if you want, but the fundus examination by your direct ophthalmoscope is enough, and it will show you the tear that basically can look like this, or the detached part of the retina. Basically can look like this, and you'll see this whitish, grayish discoloration that basically represents part of the retina that was basically ripped apart between the pigment epithelium and the neurosensory part of the retina, okay? Or you can at times see this detached part of the retina with a tear, and this tear can be horseshoe shaped. It can basically look like this. It can look like this essentially. And this horseshoe tear is accompanied with it. Typically they might have a retinal tear, and you'll see it. Of course, the retinal detachment, the complication is permanent loss of vision if you don't treat it. And that's why if you have a detached retina, you have to do surgery, no exception. But let's say in the treatment, let's say I have a retinal tear, but I don't have a detached retina. Then you do laser. We call the laser here that's used argon laser. So you'll use a specific type of laser, an argon laser. If you want to recall, there's many types of laser they use in ophthalmology. There's 3 types typically. Eczema laser, that's used in LASIK or keratoplasty. YAG laser, that's used in glaucoma and also used in post-cataract surgery complication, PCO. And then the last one, the surgery, is argon laser. Argon laser is the one you'll see it also in glaucoma, and you also see it in retinal detachment, and you'll see it in really a lot of retinal diseases, especially this one where we use an argon laser, where we basically use it to basically fix the tear, basically have this tear not go further to having a detached retina. So we'll do either laser or we can do chirotherapy, whatever it may be according to the location. That is in cases of tears without retinal detachment. If you have retinal detachment, you have to do surgery, like vitrectomy, for example, or retinoprexy, where you basically try to glue the retina together, okay? That's basically for the treatment. Of course, when I say differential diagnosis for these cases, for example, retinal detachment, I base these diagnoses based on the symptoms. This one is sudden loss of vision, but painlessly. So we go by that symptom to give you these differential diagnoses. So before we end the video, we want to look at the retinal detachment, because there's 3 types you got to know. There's the primary type or rhematogenous type, the most common by far. And then you've got the non-rhematogenous type, glaucoma, tractional, and exudative. Let's start with exudative because we don't want to get too long with it. We have something known as retinal blastoma. Basically, exudative retinal detachment is a type of detachment that occurs due to a mass. If you have a mass, just as in retinal blastoma, which you can diagnose by fundoscope, basically have a very large white mass in the retina, especially in a child that's presented to you with leukocoria, whitening of the pupil, and strabismus, squint. So you'll see this white mass, and he might come with complications of retinal detachment. So this is one of the causes of exudative retinal detachment, the retinal blastoma. And that's why I'm going to revise retinal blastoma real quickly. That's why retinal blastoma is very, very important. Not because of this complication, just in general. If you see any child, any of us in residency or internship, if you see any child that comes with whitening of the pupil, you have to assume retinal blastoma until otherwise. Especially if he has strabismus, I do fundoscopic examination, I see a mass in the retina, I do ocular ultrasound, I do orbital CT, and there's calcification in this mass, guarantee retinal blastoma. Because most of the cases here, best case scenario for this baby, you have to remove the eye, inoculation. So this is basically attributing to the seriousness of retinal blastoma. But back to the point, this is one type of retinal detachment. The other type is tractional retinal detachment. Tractional meaning, let's say part of the retina is fibrosed, like from neovascularization. That's why a lot of the causes of tractional retinal detachment are vascular related, like diabetic retinopathy, especially proliferative diabetic retinopathy. One of its complications, joining with vitreous hemorrhage and neovascular glaucoma, basically from neovascularization. That's the problem with proliferative diabetic retinopathy, is that it can actually also lead to tractional retinal detachment. Another cause of tractional retinal detachment is retinopathy of premature infants. This basically means that premature infants, less than 32 weeks, or let's say 32 weeks, or less than 42 weeks, or their birth weight less than 1,000 grams, these premature infants, when they're exposed to high oxygen therapy, the blood vessels will dilate and proliferate, and abnormal blood vessels, and they can rupture, and they can give, as a complication, tractional retinal detachment. So that's one thing to keep in mind as well. And also central retinal vein occlusion from previous videos. The most common type of retinal detachment we're going to focus on is the primary type, and there are many causes. One of them is high myopia. No, not normal myopia. I'm a myopic patient, but I don't have high myopia. We're talking about someone who has pathological myopia. We're talking about someone who has refraction in the SCA. Doesn't have the paper for prescription. When you look at the spherical, it's like minus 15, let's say. That's very, very, very myopic patient. High myopia, pathological myopia, and if you remember myopia, patient is basically, his eyeball is large. So you can think of it as the idea, if the eyeball is too large, like a balloon, it could pop. So there could be primary retinal detachment. Accumulation, it's really associated with accumulation of retinal tears here. Not a mass, not fibrosis, here retinal tears, accumulation of fluid in the retina. So one cause is high myopia. Another cause is trauma to the eye. The third cause could be retinal detachment of the other eye. So if someone has retinal detachment in one eye, that's why you have to look at the other eye. That's why whenever you have a patient with retinal detachment, when you check one eye, you have to check the other eye, because there's also a risk factor of retinal detachment for the other eye as well. Also family history as well as another risk factor. that could cause primary type. Another one we want to focus on in the video is post-cataract surgery. Basically, anyone that has cataract has to undergo surgery at some point, okay? The best surgery, again, for cataract is phaco, something called phaco, where you insert an ultrasound probe inside, and it does emulsification or destruction of the lens, okay? And then you insert immediately the intraocular lens, okay? You do this surgery, and of course, there's many complications with the surgery. We call it the best surgery, not because it has the least complication, basically it requires less suturing, but also because it's most efficient and the safest, and compared to other surgeries, but especially most efficient. But especially the complications from this surgery, when during surgery you might remove the posterior capsule by accident if you do other surgeries, or you might rupture a blood vessel with some vitreous hemorrhage or suprachoroidal hemorrhage, again hemorrhage in general. That's during the surgery. But after the surgery, there are a number of complications that might occur. The most common is PCO, posterior capsular ossification. That typically might occur regardless. Other complications is endophthalmitis. If a patient comes to you 1 week after the cataract surgery, he might complain with red eyes, sudden loss of vision, very painful eyes, photophobia, tearing. You see complete redness in his eyes. This is endophthalmitis. You have to give him antibiotics injection inside the eye. But also another complication of cataract surgery, besides the endophthalmitis and PCO and even macular edema, another complication is retinal detachment, primary type, after cataract surgery. It can occur, and in these cases, if we have retinal detachment, we treat it as we said before. But if there's a tear, by the later. If there's actual detachment, we'll do vitrectomy or retinopexy to fix the detached part of the retina, okay, and restore this patient's vision essentially. Okay, that's the end of the video.